Welcome to our live USMLE question and answer series. We had posted a question on our social media platforms last Thursday. So now we're going to be going on and kind of running through the question, taking out the key points of what it was asking you, and kind of addressing what's going on. So we are joined today by Dr. Kinslow. How are you?
I'm great. You did much better this
I did
time.
a lot better this time. I didn't pause in the middle. We're learning. It's slowly but surely. Yeah. Okay.
We're friends, guys.
We're friends. It's fine. So we're going to go straight on to the question. You good?
Sounds good.
Cool.
So, what we're going to be talking about this week is the treatment of diabetic nephropathy. I don't want to give away the hint, but it's one specific drug class we're going to be talking about. And with that, we will go to our question. So the question that was asked was, a 44-year-old man comes to the clinic with complaints of a non-productive cough for the past week. He denies fever, headache, nausea, vomiting, or bloody sputum with the cough. Patient's past medical history includes diabetes mellitus type 1 and hypertension. He denies tobacco use and drinks alcohol socially. He has no past medical history other than what was listed above. He has no past surgical history, and there is no significant family history. Physical examination reveals a temperature of 37.1 degrees Celsius, 98.8 degrees Fahrenheit, blood pressure of 146/87, and a respiratory rate of 15 breaths per minute. The patient was started on a medication recently to address the microalbuminuria found on urinalysis. Which of the following most probable medication causes the patient's symptoms? A medication preventing the conversion of angiotensinogen to angiotensin 1 and decreasing angiotensin 2. B, a medication binding to the angiotensin 2 receptor, preventing vascular smooth muscle contraction and vasopressin release. C, a medication preventing the conversion of angiotensin 1 to angiotensin 2. D, a medication that inhibits sodium chloride transport in the early segment of the distal convoluted tubule. Or E, a medication that releases nitric oxide stimulating guanylyl cyclase and increasing cyclic guanosine monophosphate, downstream effect leading to smooth muscle relaxation.
So at this time, if you guys want to take a minute and look over the question, put your answer choices in the comment section below, then we'll kind of go through, what you're looking at and, when you're reading this question, what are the main things that you're kind of taking from, like what stands out to you?
So for starters, the first thing I'm looking at is the chief complaint. So we know that he's here because he's having a cough, non-productive, which means he's not coughing anything up. It's more just a dry cough, almost like just kind of irritation, we could say. On top of that, he has no other symptoms, nothing going on. So what I look at next would be what kind of diseases does he already have? So he has diabetes and high blood pressure. So with those, we would kind of try to think along the lines of what drugs he could be on. They don't specifically say any drugs that he's on, but they do mention that he was put on a new medication recently. So they don't give an exact date, but the fact that he was put on a new medication recently and now he's been having this non-productive cough, we kind of think along the lines of, okay, this is probably a medication side effect. So obviously, from the actual question and the answer choices provided, we know that it is due to a medication side effect. So then the question becomes, which medication could this patient possibly have been put on whose side effect is a non-productive cough?
So we have one person who's written in and said that he thinks it's C. I remember on social media, on our various platforms, they were also writing in a C. So the ACE inhibitors cause respiration and dry cough. Okay. We also have somebody who's writing in saying A.
Okay.
Okay.
Good thoughts, good thoughts.
Yeah.
So what I want to do is so each of these choices is describing the mechanism of action of a medication that has already been well discovered, well researched kind of thing. So I just want to go forward and look at what the drugs are. So choice A, our renin inhibitor, is aliskiren. Choice B was an angiotensin receptor blocker. Choice C was our ACE inhibitors. Choice D was a thiazide diuretic. And choice E was a nitrate. So now, if we go back to the question, sorry, just because the next slide is the answer, knowing what all of these mechanism of actions actually, what drug corresponds to it, anyone want to change their answer, or is everybody sticking with what they already guessed? Just give them
a couple seconds.
Answer in the chat below.
What a pro.
F's in the chat. Okay, so it looks like, good.
There it goes.
All right, so it looks like everyone pretty much got it as far as the people that responded. So the drug in question is our ACE inhibitor. So our ACE inhibitor is so ACE inhibitor stands for angiotensin-converting enzyme inhibitor, and angiotensin-converting enzyme is going to, ironically, convert angiotensin 1 to angiotensin 2.
It's a concept.
So pretty aptly named drug, if you ask me.
It is.
So for understanding this, I just want to do a little background before we talk about the actual disease and the drug in question here. So we have our renin-angiotensin-aldosterone system. So renin is going to be released from the juxtaglomerular cells, so close to the distal convoluted tubule. They're going to kind of sense any changes in blood pressure, sodium, or your sympathetic tone. And if they are triggered, they're going to release renin, which will convert angiotensinogen from angiotensin 1. And then in the lungs, ACE is going to convert to angiotensin 2. Angiotensin 2 has a lot of effects on the body. Also, aldosterone to cause you to secrete potassium and retain sodium. So the goal of the renin-angiotensin-aldosterone system is to increase your blood pressure. But two of the side effects of angiotensin 2 that we kind of want to focus on here is it's a potent vasoconstrictor, which will lead to your blood pressure increasing. And it's also going to constrict the efferent arteriole, which will lead to an increased GFR, increased filtration fraction, and you're going to have a built-up pressure in your glomerulus. So if we look at this picture here, you have the afferent, where blood is going to come into the glomerulus, and the efferent, which is going to carry the blood away from the glomerulus, anything that wasn't filtered. So if you constrict the efferent, you're going to have a lot more of this blood just kind of sitting in this glomerular space, and you're going to have an increase in the pressure, and you're going to have more blood available to get filtered. So increased GFR and an increased pressure. So for our patient, we have a diabetic patient. So diabetic patients very commonly get renal failure. It's actually the most common cause of renal failure in the US. So diabetics obviously classically have a high blood sugar. So they have a lot of glucose going around in their blood. The blood, almost all of it is going to go to the kidneys at some point and be filtered. All of that glucose can lead to non-enzymatic glycation of the tissue proteins. Specifically in the kidney, it'll expand the mesangium, and then it'll lead to thickening of the basement membrane, which if you thicken that membrane, so the membrane is designed very specifically to only let very small molecules, specifically electrolytes like sodium, chloride, things like that, into the actual proximal convoluted tubule, etc., in your nephron. So if that thickens, those openings get a little bit bigger, and that allows things like proteins to spill through. So anytime you see protein in the urine, that's not necessarily a normal finding. So like we said, angiotensin 2 will cause the efferent to constrict, which increases the glomerular pressure. So we get glomerular hypertension and the increased GFR, which leads the glomerulus to get larger. You can get scarring, and that will just further progress the nephropathy in these patients. So, like I said, you have, as the thickening gets worse and worse, you will have little tiny proteins called microalbumin that will leak into the urine. And as it progresses and gets even worse and worse, you have albumin itself, which is a pretty large protein that can spill over into the urine. So one of the things that you want to do for all diabetic patients, especially in the US, because like I said, it is the most common cause of renal failure in the US. Yearly, you're going to check a microalbumin level in these patients, and that's going to kind of show you the disease progression in these patients. So you're looking for microalbumin or just any protein in the urine if you're doing like a UA. And as far as the treatment, you want to give them strict glycemic control. So the less glucose you have, leading to that non-enzymatic glycation of proteins, the less likely they are to have this progression. You also can protect their kidneys by putting them on ACE inhibitors or angiotensin receptor blockers. And all that's really going to do is prevent that angiotensin 2 causing the high blood pressure and the constriction of the efferent arteriole. So if we look at the other options, a lot of these drugs do also act on this renin-angiotensin-aldosterone system. So we want to kind of highlight that. So aliskiren is a renin competitive inhibitor. So competing with renin, the beginning of the renin-angiotensin-aldosterone system will lead to a decrease in angiotensin 2, but also decrease angiotensin 1. And some of the side effects you get with that are diarrhea, headache, abdominal pain, GERD, angioedema, and a cough. But it's not as common to cough as you would with an ACE inhibitor, and this drug is much less used than an ACE inhibitor. And actually, this drug is contraindicated in pregnancy, renal insufficiency, and diabetic nephropathy. So you wouldn't want to use this drug in diabetic patients to protect their kidneys. So angiotensin receptor blockers, they usually end in sartan. So losartan is a classic one that a lot of people know. It's going to prevent the contraction of vascular smooth muscle, thirst response, vasopressin release, aldosterone secretion, and release of adrenal catecholamines. Most of that was mentioned in the actual answer choice. So this is going to block the receptors that angiotensin 2 is going to bind to actually lead to these effects. So side effects, hypotension, angiotensin 2, like we said, vasoconstriction, high blood pressure. So if you block it, you could get the opposite effect. You can cause acute renal failure because a lot of healthy people will constrict the efferent in order to maintain their GFR, and high potassium as well. Again, this has to do with aldosterone being blocked. So angioedema and cough as well, but this is a much lesser extent than ACE inhibitors. So classically, if you have somebody on an ACE inhibitor and they start to develop this cough, you would usually switch them over to an angiotensin receptor blocker because they're less likely to get that cough. We'll talk about it in a little bit, but it has to do with one of the other uses of ACE, the actual angiotensin-converting enzyme in the lungs. So the other two drugs aren't acting on the renin-angiotensin-aldosterone system, but as there were answer choices, we want to go through them. Thiazide diuretics, so classically hydrochlorothiazide, used for hypertension, nephrogenic diabetes insipidus, so not diabetes mellitus like this patient had, and for edema from heart failure, just kind of get rid of fluid and sodium. The adverse effects of this are known as hypergluc, so hyperglycemia, hyperlipidemia, hyperuricemia, and I believe the C is hypercalcemia, potassium and low sodium as well. So one, cough isn't even an adverse effect, so can't be that one. And nitrates is a drug commonly used in angina and acute coronary syndrome, given sublingually to relieve chest pain associated with angina. The adverse effects of those: headache, orthostatic hypotension. So as you change positions, let's say from seating to standing, your blood pressure drops. Classically, you can pass out, and an elevated heart rate, tachycardia. Side note here, they love asking this question. Nitrates and sildenafil, which is Viagra, have the same mechanism of action. So if you actually take those together, you can lead to severe hypotension, which can cause end organ damage, and patients can actually die from taking both of these. So now we'll focus more on the ACE inhibitors. Classically, they end in the pril, so captopril, lisinopril, things like that. So in the lung, like I said, you have the ACE enzyme, so angiotensin-converting enzyme, which will cause angiotensin-1 to become angiotensin-2, but it also prevents the breakdown of bradykinin, which is a vasodilator. So that bradykinin is what actually, the excess of bradykinin is what leads to the cough and the angioedema. So that's why with ARBs, you don't get that as much, because the angiotensin-converting enzyme can still break down the bradykinin, but you're actually blocking the effects of angiotensin-2. So that's why if they have the reaction to ACE inhibitors, you want to switch them over to an angiotensin receptor blocker. So I kind of already went through a lot of this, but ACE inhibitor, you're going to prevent the action of angiotensin-2 on the efferent arteriole. So you decrease the pressure in the glomerulus, and you also will decrease the filtration fraction. So how much is actually going through the glomerulus and getting filtered, whether it continues on or goes back into the bloodstream. And this is going to slow that basement membrane thickening. So that's kind of the theory behind why we put our diabetic patients on ACE inhibitors, just to kind of protect their kidney before it gets to the point of, severe end organ damage and having albumin in the urine. So other uses for ACE inhibitors, so high blood pressure. Like we said, angiotensin-2 is a vasoconstrictor, leads to increased blood pressure. So you can use ACE inhibitor for that. In patients with heart failure, you can give them this drug, and it actually decreases mortality because it will decrease the remodeling of the cardiomyocytes by the actions of angiotensin-2. It's one of the few drugs that you can give to heart failure patients that decreases mortality. Other ones would include beta blockers and aldosterone receptor antagonists like spironolactone. Also, obviously diabetic nephropathy as we're talking, but any sort of proteinuria, usually you would want to put them on ACE inhibitors to kind of protect their kidney. So if they're not diabetic, but they're still having proteinuria, ACE inhibitor would be one of the things that you would want to go for. So the two most common side effects of ACE inhibitors is going to be the cough, so a dry or non-productive cough, and then also angioedema. Both of these are resulted from an increased bradykinin because you're not breaking it down. Angioedema is classically seen in people who have the hereditary C1 esterase inhibitor deficiency, but it can happen in other people. Fun fact about the angioedema, it can happen at any time, even if you have C1 esterase inhibitor. So you could have a C1 esterase inhibitor deficiency and be on an ACE inhibitor for 5 years, and 5 years later, just one day wake up, tongue, face swollen. I've actually seen this pretty often in my clinicals. I thought it was more, within a couple weeks, couple months, but I've seen people be on ACE inhibitors for a year or so and then actually get this. So those are the two most common side effects you want to think of. If they have those, usually it's switch them over to an angiotensin receptor blocker. But the other ones, so teratogen, So if you have a pregnant lady who takes an ACE inhibitor, it can lead to renal malformations in their baby. Can also increase the creatinine because you are decreasing the GFR. Can lead to hyperkalemia because you're blocking angiotensin 2, leading to aldosterone release, so you would retain potassium. And then again, hypotension because you're blocking the vasoconstrictive effects. And like we said, if cough or angioedema, switch them to ARB because same kind of mechanism, but you're going to have less of the adverse effects. And that pretty much covers ACE inhibitors and diabetic nephropathy. If you have any questions, please put them in the chat. I will answer to the best of my ability and knowledge. I'm not perfect, guys. I make mistakes too, I promise.
Okay, so we'll give you a couple seconds to type in any questions if you have them. All of these have been recorded, so if you want to watch them, if you came in towards the middle, you can start them all from the beginning and hear all of your great explanations. So thank you so much for everybody who is tuned in. We will be posting a new question next Thursday. And then that following Thursday, we will be going on live again as we kind of break down, just like we did today, just with one of our other USMLE counselors. So Thank you so much for joining us today, everyone. If no one has any other questions, we'll be signing off. Okay. Have a great day, everyone. Enjoy your weekend.
Thanks.